Today we're going to set up chest tube drainage, which is the Atrium Oasis. So if we are beginning at the very beginning, we're going to obtain the drainage from central supply, and then when you open the package, there's actually directions in the package if you forget, but it's very simple. On the back of the bottle, it comes with a vial of your sterile saline, and you would just put that in the little port right here, and it's blue on the new ones. That will fill your air leak chamber up to the dotted line. And there's dye in here, so it turns blue. This one is a little bit older, so it's not as bright a blue as it normally would be. So that gives you your underwater seal. And then there's a little stand on the bottom. You just can flip it open, and that will help to keep it from tipping over. All right, so then once the chest tube has been inserted, the common reasons for a chest tube is pneumothorax, fluid. Those are the two most common reasons to have a chest tube. All right, so we've got our chest tube ready, and then once the physician has the chest tube in, we just connect it. Normally I would have gloves on, and then I would want to tape this connection because we don't want that to loosen. Right now we're to underwater seal. Then if the physician wants suction set up, we're going to have our suction tubing, and we're going to turn it on, and this should be at least 80 on the side. The way that we determine how much suction the chest tube's going to give is this little vial, this little dial right here. So it comes out of the package at -20, and that's the normal amount they usually want. Then we just take the suction tubing and we connect it to the same place where we put the water in. And then if you see down here, if you see bubbling, and all your connections are tight, that means you have an air leak. Verify you do have suction working. Your little orange indicator needs to be out to the arrow. And so we know that our suction is working correctly. And then as the patient drains fluid, it's going to drain over here. This is your output. So every shift you would take a Sharpie, and you would mark the date and the time, and then that would be your output to put into your INO. Then the next shift would make another line, and so forth. Just keep in mind, if this would tip over and the fluid gets all mixed up, the best thing to do would just go get a new drainage device, set it up just like we did with the water. When it's all ready to go, we just switch it over.
Going back over here real quick, this connection here, what kind of tape would you say is the preference?
I prefer this microfoam tape, and I also like it for the dressing because it really holds it nicely. And speaking of the dressing, that is part of your assessment. When you're assessing the patient that has a chest tube, you want to assess their whole respiratory status, vital signs, oxygen saturation, lung sounds, and their dressing all the way down to the drainage device. The dressings really should be changed once a day, so just ask the physician for an order. If they don't specify to use Vaseline gauze or not to use Vaseline gauze, I would just recommend take the dressing off and see what's there, and then replace with the new. After you've cleaned around it, if it had Vaseline gauze, then put Vaseline gauze, and then a piece of gauze with the slit. And I like this kind of tape. You want to make sure it's real secure so that it doesn't pull. We don't want to dislodge the chest tube.
And this is normally sutured underneath there, is the usual. So, but these are all things that you want to make sure that when you talk to your pulmonologist when they're around, that you're asking those questions, making sure that the site is correct. If there's changes in your patient's condition or the amount of output that we're seeing from the device, that we're talking about that, because the physician may say it's time to change the mode at that point. So right now we're to suction, but the physician might want to say, let's put it to water seal. So what does water seal mean?
So if we're going to change it from suction to water seal, we're just going to disconnect here. And now we are at water seal, and we could turn our suction off.
So very simple.
And you can also take it off of suction if the patient needs to go to the restroom, go to x-ray. It's still underwater seal, and then when they come back, if suction is still ordered, then we would just reattach the suction.
Awesome. Okay. And in this case, I just want to point out that this is clamped just because we don't want to have it pulling air through the line right now, because
it's not a real person.
Yeah.
We would
But
we would never clamp this without an order.
Yeah, you have to have an order to clamp this. And there will be other criteria as well for that. Okay.
So when it's time to change, if your drainage bottle's full, like I said, we're just gonna get a whole new drainage bottle, set it all up, and then we can just disconnect, of course with gloves on, and just maintain sterile technique. We're gonna disconnect and put the new bottle here, and we can continue to drain. And you don't want dependent loops like this. You wanna make sure the loops are,
Fluid will get hung up.
yeah.
And it is okay if you have fluid that is sitting in an area, you don't ever want to squeeze it or push it through, but you can always pick it up to allow it to drain out properly. You just don't want to have it running back into the patient.